Welcome. In the previous session, we discussed about the indications and techniques of trabeculectomy and adjuncts which can be used during trabeculectomy. In this session, we will be discussing about the complications of trabeculectomy. Unlike many other surgical procedures, post-operative management following trabeculectomy is as important as the surgery itself to maintain a high success rate of the procedure. And we'll classify the complications as intraoperative complications and post-operative complications. Most common intraoperative complications include conjunctival buttonholing, scleral flap tear, and hemorrhages. Conjunctival buttonholing is a tear in the conjunctival flap which overlies the bleb and which thus may potentially lead to a bleb leak. Conjunctival buttonholing can be prevented from occurring by holding the conjunctiva only at its incision with a non-toothed forceps and by using a vascular needle which is round in cross-section to close the conjunctival flap. Following conjunctival buttonholing during surgery, the conjunctival tear should be immediately and securely closed prior to proceeding further to prevent extension of the conjunctival tear. And to close a small buttonhole, a horizontal mattress suture should be placed, and for a large buttonhole, a running suture should be used. If secure and complete closure is not possible, the site of the scleral flap should be shifted to another appropriate location. The scleral flap can be torn or disinserted during surgery, and this should be repaired by suturing with a 10-0 nylon suture. And in a thin sclera, use of a graft such as donor sclera can help prevent cheese bearing during this repair. Intraoperative hemorrhage following trabeculectomy can be either in the subconjunctival space from the iridectomy site or in the suprachoroidal space. Subconjunctival hemorrhage promotes scarring and should be avoided, and it can be prevented by using gentle but adequate cautery. However, excessive cautery must be avoided because that can lead to scleral thinning and scarring. The scleral flap should be sutured only after bleeding in the bed under the scleral flap stops, else sclerostomy may be obstructed by a blood clot. Bleeding from iridectomy site usually stops spontaneously or may be stopped by applying pressure with a sponge. Cautery should not be done at this site because it may lead to vitreous prolapse. Intraoperative choroidal hemorrhage presents as a shallowing of anterior chamber with the orange-red fundus glow being replaced by a dark red mass, and it is potentially a blinding condition. The procedure should be stopped, and immediate and secure closure of the sclera and conjunctiva is essential, and this is very important to remember. Additionally, anterior chamber can be formed with viscoelastics, and intravenous mannitol may be administered to lower the intraocular pressure. Risk factors for intraoperative choroidal hemorrhage include elevated intraocular pressure preoperatively, particularly if more than 30 mm of mercury, and that is why many surgeons prefer to give mannitol infusion immediately preoperatively. Other risk factors for intraoperative choroidal hemorrhage include elevated blood pressure, tachycardia, myopia, aphakia or pseudophakia, vitrectomized eye, and use of anticoagulants by the patient. Other intraoperative complications of trabeculectomy include Descemet's membrane detachment, injury to the crystalline lens, and vitreous prolapse. We'll classify the post-operative complications into those presenting with low intraocular pressure with or without a shallow anterior chamber, those presenting with elevated intraocular pressure with a deep anterior chamber, and those presenting with elevated intraocular pressure and a shallow anterior chamber, and those which have no particular characteristic IOP level or depth of the anterior chamber. Postoperative complications with low IOP with or without shallow anterior chamber include overfiltration, Bleb leaks, and aqueous hyposecretion. Hypotonic maculopathy and choroidal effusion occurs as a result of low intraocular pressure, and they do not by themselves cause low intraocular pressure, and this is very important to understand. Overfiltration occurs due to a low resistance to aqueous outflow from the anterior chamber to the subconjunctival space, and the causes may be inadequately tightened scleral flap sutures, buttonholing of the scleral flap, or a corneoscleral fistula situated under the margin of the scleral flap. Signs of overfiltration include, in addition to low intraocular pressure and a shallow anterior chamber, an exuberant bleb with no bleb leak. So Siddle's test will be negative when the patient has low intraocular pressure due to overfiltration. When there is only iris cornea touch with a clear cornea, conservative measures may be instituted initially, and these include reducing topical steroids, because steroids inhibit the healing response, and so reducing topical steroids is expected to promote healing and reduce overfiltration. Other measures include cycloplegic administration, which helps in pulling the lens iris diaphragm posteriorly to deepen a shallow chamber, viscoelastic injection in the anterior chamber, and application of a pressure patch over the upper eyelid in the area of the scleral flap, while instructing the patient to keep the other eye open and look straight ahead. We'll be seeing a diagram of pressure patch with the discussion on Bleb leaks next. But if there is lens cornea touch or iris cornea touch for more than 3 to 7 days, or choroidal effusion with the bully of the choroidal effusion touching each other, or hypotonic maculopathy, additional flap sutures will be required to tighten the scleral flap and reduce overfiltration. Late hypotony can occur in patients who have received mitomycin C during trabeculectomy, and signs of late hypotony include low intraocular pressure and large, thin and avascular blebs. This type of bleb should be distinguished from tenon cyst, which we have discussed in the previous session and discuss further when we discuss failure of the bleb. Treatment options for late hypotony include autologous blood injection into the bleb, NDAG laser treatment of the bleb, revision of the bleb, revision of the scleral flap with tighter sutures, or application of a scleral patch graft. We'll discuss about bleb revision when we discuss bleb leaks next. Leakage from the bleb can occur from the conjunctival incision, buttonholing of the conjunctival flap, or from erosion of scleral flap sutures through the conjunctiva, and bleb leaks increase the risk of infection and bleb fibrosis. Patient with bleb leak may present with epiphora, and on examination we'll see, in addition to low intraocular pressure and shallow anterior chamber, a shallow or a flat bleb as seen here in this photograph in this portion of the bleb, and a positive Siddle's test as seen here in the photograph of the same patient. Bleb leaks can be initially treated conservatively by reducing topical steroids in order to improve the healing of the leakage site, administering aqueous suppressants despite presence of a low intraocular pressure, because reduction of aqueous flow through the leakage site promotes healing of the leakage site, and application of a pressure patch as shown here in this diagram by placing a pressure gauge over the upper eyelid, over which another patch is placed with adhesive tapes, and instructing the patient to keep the other eye open and keep looking forwards. If the leak does not seal within 2 to 3 days, or there is lens cornea touch or choroidal effusions that touch, or hypotonic maculopathy, the leakage site should be sutured, failing which either a conjunctival autograft or an amniotic membrane can be used to seal the leak. Late bleb leaks usually occur in patients receiving antifibrotics during surgery, and these patients typically have thin avascular blebs. Valsalva maneuver by the patient may also cause late bleb leaks. And for late bleb leaks, conservative measures may be attempted initially, but most such cases require bleb revision, in which conjunctiva of the bleb is resected and replaced by advancing the conjunctiva posterior to the bleb, or by a conjunctival autograft. Aqueous hyposecretion from ciliary body shutdown can also present with low intraocular pressure with or without a shallow anterior chamber, and it is usually caused by either a severe post-operative inflammation or intraocular penetration of mitomycin C. And in patients with aqueous hyposecretion, will find, in addition to low intraocular pressure and a shallow anterior chamber, a low or a flat bleb. Treatment of aqueous hyposecretion is similar to other causes of low intraocular pressure such as overfiltration and bleb leaks, except increasing the frequency of topical steroids. Hypotonic maculopathy results from low intraocular pressure, as we have discussed, and it presents with edema of the optic nerve and or macula as seen here in this photograph, with macular and or choroidal radial folds and dilated retinal vessels. In this situation, if IOP is not restored promptly, hypotonic maculopathy can become permanent. Risk factors for hypotonic maculopathy include young age and myopia, and in this group of patients with low IOP, hypotonic maculopathy is more common than choroidal effusion. Treatment of hypotonic maculopathy is early surgical correction of the cause of low intraocular pressure. Choroidal effusion also occurs secondary to low intraocular pressure and is more common in elderly patients in whom secondary to low intraocular pressure choroidal effusion is more common than hypotonic maculopathy. And in patients with choroidal effusion, we will find in addition to low intraocular pressure and a shallow anterior chamber, ophthalmoscopy will reveal choroidal detachment as grayish dome-shaped elevation in the fundus anchored in the region of the vortex veins. Treatment of choroidal effusion is treatment of the cause of low intraocular pressure, and when these measures are ineffective, the suprachoroidal fluid needs to be drained by posterior sclerotomies made in the inferior quadrant. Causes of elevated intraocular pressure with a deep anterior chamber following trabeculectomy include sclerostomy obstruction, tight scleral flap sutures, and fibrosis of the bleb. The internal ostium of the sclerostomy can be blocked by blood clot, fibrin, vitreous, or iris, and gonioscopy is essential to visualize the internal ostium of the sclerostomy and to determine the cause of obstruction, and this is very important to remember. Signs of sclerostomy obstruction include, in addition to raised intraocular pressure, deep anterior chamber, a low bleb, and visualization of the cause of obstruction with gonioscopy. Nd:YAG laser is often effective in releasing iris from the sclerostomy, and blood and fibrin usually disappear with time, but their removal can be accelerated with either digital massage or tissue plasminogen activator. We will be discussing digital massage further when we discuss fibrosis of the bleb. Tight scleral flap sutures results in obstruction to aqueous outflow, and these patients will present with raised intraocular pressure, a deep anterior chamber, low bleb, and a patent internal ostium of the sclerostomy. And in these patients, initially digital massage of the globe should be instituted to force aqueous through the scleral flap margin. And when digital massage is successful, it will result in formation of the bleb and lowering of intraocular pressure. If digital massage fails to lower the intraocular pressure, scleral flap sutures need to be removed, and this procedure is usually effective within the first 3 weeks following surgery and should be guided by the appearance of the bleb and not the intraocular pressure. Only one suture should be removed at a time, followed by observation of the response of the bleb, the intraocular pressure, and the anterior chamber depth. Removal of suture should neither be too early, which may result in overfiltration, nor too late, which may result in failure of the procedure. Interrupted sutures can be broken with argon laser through the conjunctiva, and this procedure is called laser suture lysis. Fibrosis of the bleb leading to failure of the bleb to lower intraocular pressure occurs mostly in the subconjunctival space as shown here in this diagram, but can also occur within the scleral flap. And fibrosis in the subconjunctival space can also lead to formation of an encapsulated bleb, also called a tenon cyst. In a tenon cyst, there is a fibrous layer lining the inner surface of the conjunctiva, and these fibrous layers are the site of obstruction to aqueous outflow, resulting in failure of the bleb. Fibrosis of the bleb is particularly likely to occur if in the early post-operative stage there is poor aqueous flow through the bleb, conjunctival hyperemia, and subconjunctival hemorrhage. Treatment of bleb failure depends on the amount of time passed since trabeculectomy. Early on, bleb failure may be managed by increasing the frequency of topical steroid application, which reduces the healing response in the subconjunctival space, or by application of digital massage. Digital massage can be applied by the patient himself or herself over the inferior sclera through the lower eyelid, and it should be applied for 15 seconds at a time, several times each day. Digital massage can also be done by the surgeon on the slit lamp by applying pressure over the upper eyelid posterior to the bleb, while the patient is looking downwards. Subconjunctival injection of 5-fluorouracil can also be administered for a failing bleb. Internal bleb revision can be attempted when the sclerostomy is presumed to be the site of fibrosis, and in this procedure a paracentesis is made 180 degree away from the bleb. Viscoelastic is injected to deepen the anterior chamber, and a cyclodialysis spatula is inserted through the paracentesis, passed across the anterior chamber and inserted through the internal ostium of the sclerostomy. The cyclodialysis spatula is then used to gently lift the scleral flap, and with a side-to-side movement of the cyclodialysis spatula, an attempt is made to break the adhesions along the scleral flap margins. Bleb needling is typically indicated for an encapsulated bleb and is most effective 4 to 6 weeks following trabeculectomy. In this procedure, a bent 26 or 30G needle is used to enter the conjunctiva 5 to 10 mm away from the bleb. The tip of the needle is then passed through the subconjunctival space into the bleb and is used to disrupt episcleral fibrous tissue with sweeping movements inside the bleb. When these procedures fail to repair a failed bleb, other interventions such as bleb revision, repeat trabeculectomy at another appropriate site, or tube shunt surgery will be required. Post-operative complications which present with elevated IOP and a shallow anterior chamber include malignant glaucoma, suprachoroidal hemorrhage, and pupillary block. Malignant glaucoma presents with shallow chamber, particularly centrally, with a high intraocular pressure, and the bleb usually appears formed. And in this diagram, we see a patient presenting with malignant glaucoma following trabeculectomy. We have discussed the management of malignant glaucoma in a previous session. Delayed suprachoroidal hemorrhage presents with severe pain along with nausea and severe reduction of vision, and in addition to a shallow chamber, particularly centrally, and a high intraocular pressure, the bleb usually appears formed, and on fundus examination dark brown dome-shaped elevations may be seen. Management of suprachoroidal hemorrhage has been discussed in a previous session. Pupillary block can occur if the iridectomy done during trabeculectomy is inadequate, and these patients present with elevated intraocular pressure and shallow chamber, particularly peripherally, due to iris bombay formation. Pupillary block needs to be treated with laser or surgical iridectomy, as we have discussed in a previous session. Other complications which can occur following trabeculectomy include loss of central vision, which is also known as wipeout or snuff out, and incidence of this complication has been reported to be 0.8% of all patients undergoing trabeculectomy. Risk factors for this complication include older age, advanced visual field defect with a central island remaining, or fixation splitting visual field defect, and low post-operative intraocular pressure. These risk factors are not considered as contraindications to trabeculectomy, but patient counseling is important. A Dellen is a depression in the peripheral cornea which occurs adjacent to a localized area of conjunctival elevation and thus can occur adjacent to a bleb. Dellen usually resolve with lubricant administration but may lead to infective keratitis. Progression of cataracts are known to occur following trabeculectomy and can occur due to long-term therapy with anti-glaucoma medications, surgical trauma, and post-operative shallowing of the anterior chamber. And cataract surgery in an eye with prior trabeculectomy is complicated by small pupil, zonular weakness, and these are particularly found in patients with pseudoexfoliation and rise in intraocular pressure and or failure of bleb following the cataract surgery. Bleb-associated infections are potentially vision-threatening and may occur in up to 6% of patients undergoing trabeculectomy. And unlike post-operative infections following other surgical procedures, bleb-associated infections can occur months to years later, and this is very important to remember. Most common organisms in delayed onset bleb-related infections are Haemophilus, Staphylococci, and Streptococci. Risk factors of bleb-associated infections are thin-walled blebs, bleb leaks, use of antifibrotic agents, which may lead to the occurrence of these two risk factors, inferior position of a bleb, long-term antibiotic use leading to antibiotic resistance, blepharitis, and conjunctivitis. Symptoms of Bleb-associated infections include pain, redness, tearing, and blurring of vision. Bleb-associated infections have been described as occurring in 3 stages. In stage 1 or in the stage of Blebitis, we will find a localized white infiltrate in the region of the bleb surrounded by conjunctival hyperemia, which can be localized. In stage 2, in addition to Blebitis, we will find anterior chamber inflammation, and in the third stage of Bleb-associated endophthalmitis, as shown here in this photograph, in addition to infiltrate in the region of the bleb and a diffuse conjunctival hyperemia, we will also find hypopyon and or vitreous inflammation. Blebitis has to be treated with frequent topical antibiotic administration, and for bleb-associated endophthalmitis, in addition to frequent topical antibiotics, vitreous tap or vitrectomy should be done in addition to administration of intravitreal antibiotics. Blebitis has a relatively good prognosis, but bleb-associated endophthalmitis has a very poor prognosis. And to prevent the occurrence of bleb-associated infections, any episode of blepharitis or conjunctivitis should be aggressively treated following trabeculectomy, and patients must be made aware of the symptoms and signs of bleb-associated infections. Other complications which may occur following trabeculectomy include spontaneous high fever, which may occur from cut ends of the Schlemm's canal or new vessels growing near the internal ostium of the sclerostomy, cystoid macular edema, lid changes such as ptosis or eyelid retraction, and symptomatic or dysesthetic bleb such as overhanging blebs as seen here in this photograph, which may require removal of excess conjunctiva of the bleb. This chart shows a very important algorithm to diagnose post-operative complications following trabeculectomy and considers the intraocular pressure, the depth of the anterior chamber, and the appearance of the bleb following surgery. Patients with a low intraocular pressure with or without a shallow anterior chamber may be having a bleb leak or aqueous hyposecretion if the bleb is low or absent, or overfiltration if the bleb is present. And in patients with high intraocular pressure and a shallow anterior chamber with or without a formed bleb, choroidal hemorrhage, malignant glaucoma, and pupillary block are possibilities to exclude. Patients with a high intraocular pressure and a deep anterior chamber and a low or absent bleb may be having sclerostomy obstruction, tight flap suture, or fibrosis of the bleb. And a localized cystic bleb with deep anterior chamber and a high intraocular pressure indicates an encapsulated bleb or tenon cyst. To recap the salient points, post-operative management following trabeculectomy is as important as the surgery itself to achieve long-term success of the procedure to lower the intraocular pressure effectively. Intraoperative complications during trabeculectomy include conjunctival buttonholing, scleral flap tears, subconjunctival hemorrhage, Descemet's membrane detachment, injury of the crystalline lens, and suprachoroidal hemorrhage. Post-operative complications presenting with low intraocular pressure with or without a shallow anterior chamber include overfiltration, bleb leaks, and aqueous hyposecretion. Low intraocular pressure can lead to hypotonic maculopathy or choroidal effusion. Post-operative complications presenting with high intraocular pressure and a deep anterior chamber include sclerostomy obstruction, tight scleral flap sutures, and fibrosis of the bleb. Post-operative complications presenting with high intraocular pressure and a shallow anterior chamber include malignant glaucoma, choroidal hemorrhage, and pupillary block. Post-operative complications which have no particular association with either the level of the intraocular pressure or the depth of anterior chamber include bleb-associated infections, Dellen, cataract progression, loss of central vision, spontaneous hyphema, lid changes such as ptosis or lid retraction, cystoid macular edema, and dysesthetic bleb. Thank you for listening.